I now invite the panel on stage. The young and agile Dr. Vasanthi, who's recently received the Lifetime Achievement Award from the South Indian Society of Anesthetists. Dr. Vasanthi is a graceful human being, an eminent teacher, and anesthetist par excellence. And she is an inspiration for anyone who works with her. Welcome, ma'am.
I'm the young one.
Dr. SAJITH was here. Oh, he's on stage already. Dr. SAJITH is the head of the Pediatric Pulmonary and Critical Care Department at Amrita Institute, Kochi, and he's dual trained in pediatric and critical care and pediatric pulmonology in India, UK, and Canada. His special interests are in pediatric lower airway anomalies and long-term ventilation. Welcome, Dr. SAJITH. Dr. KAALAN is hopefully online.
Yep.
And hopefully awake. We're going to let you go soon.
Here.
Yeah, sure. Thank you, the organizers, for giving me this opportunity to be part of this program. I was actually a delegate, and when I told Thiru that I'm a delegate, he said, we'll invite you to a panel. So I made some scenarios, pretty real scenarios, because over my career in intensive care and pulmonary, I have come across these real scenarios. So it's a 5-year-old child who is day 2 post-op single stage LTR, accidentally extubated around 8 p.m. in the ICU. His saturation is 98% in room air and he has mild respiratory distress. The question to the panelists is, which of the following would you do? The first scenario is do nothing and discuss regarding further plan next morning, as he's stable, he's breathing fine, there's no issues. Second is the pediatric intensive care on call would intubate him immediately in the ICU with a laryngoscopy, or leave him on CPAP overnight and do the same thing as in the morning. And the last option, which I have suggested, I mean, there might be more options than this. This is I'm being imaginative to come up with these different options. Inform the surgeon immediately and take him to operation theatre to retube him. So I'll start with Dr. KAALAN, or maybe Madam, if you want to.
KAALAN is a better
Okay, fine. I'll start with Dr. KAALAN. And I mean, one thing is what to do when this happens. The other thing is what do you tell the intensivist in advance in such a scenario?
Sorry,
Yeah,
I didn't hear that.
I want to hear your perspective. Yeah.
Yeah, so I actually would choose option E on your list.
I don't have any.
Which would be a slightly different combination of those choices. It would be a combination of option D and option A, where I would inform the surgeon immediately. But then I think in a lot of those circumstances, we may decide together to watch and wait and step back and support that patient conservatively and not do anything.
So that's the other thing I wanted to ask, especially the ENT surgeons. Like, you say you wanted this tube for 5 to 7 days. How particular you are that this tube has to be in for 5 to 7 days? Like, what does that tube do for the 5 to 7 days?
It's very, very patient specific. You know, we have at that moment, you know, at the moment that we put that tube in, we're looking at that graft and we're thinking that this graft would benefit from that time of stenting. But the moment that tube comes out, that cost-benefit equation has now shifted. And the reintubation introduces a downside that may change our equation for how long we actually prefer to stent that airway. And if we were on the fence thinking, oh, you know, maybe I could get away with 2 days, maybe I'll just do 5 just to be on the safe side. Once that tube comes out, I may change my mind. So it's worth the conversation, even if it's in the middle of the night, in my opinion.
Thank you for that. We'll go to the next scenario where you actually have a double stage LTR. So it's not a single stage with a trach. What is your approach if a similar situation, the patient actually gets accidentally decannulated? It's a fresh trach. The child didn't have a trach before, and the person on call is not able to put it back in the ICU. I'll ask this question to Dr. SUDEEP.
So it's a double stage LTR. The tracheostomy tube is the only airway. sometimes during double stage LTA, the upper end is sutured off and we don't have any airway up, sir. So I think even like Dr. Thiru gives an airway plan, as I already mentioned. If we are not able to put it immediately back, even a smaller size ET tube can be done. I feel that is the safest approach, and we are much easier and comfortable with that approach.
Thank you, Dr. Sudeep. Madam, you want to add anything in this scenario when there is an accidental decannulation where you don't have an upper airway? One message I wanted to pass across is that you cannot back this patient from up. So naturally, when somebody decannulates,
it has to be done. We have to somehow get at the airway. So I don't think there will be a situation if somebody knows how to put the tracheostomy back when it comes out. I mean, I don't think it's difficult. So it's really going to be a matter of who's doing it and where they're doing it. I think that makes a big difference. And of course, you have to inform whoever, the anesthetist or the surgeon, and to come and see the patient immediately. I don't think it'll be difficult. Like Sudeep said, putting in an endotracheal tube when there's a hole already, at least that will help, definitely.
Thank you for that, ma'am. Dr. KAALAN, you want to add anything to that scenario? This is actually a made-up scenario. To be honest, I just made it up.
Well, I can tell you that that is made up in your mind, but that story has absolutely occurred. One of my mentors, Mike Rutter, has shared a story with us of a patient who had that very same scenario. And you said that the patient did not have a tracheostomy prior to this procedure, which told me that this stoma was a fresh trach.
Yeah.
And that a fresh trach with a stent in place is one of the most dangerous scenarios that patients can have in the ICU, because they look so good, they're so stable, they have a trach in, so everyone feels very comfortable. But if that trach falls out, it's very possible that can be a disaster, because a patient that I heard a story of had that happen. It was actually on the floor, and the respiratory therapist couldn't get the trach back in. The fellow that responded couldn't get the trach back in. And it was about 30 minutes before anybody got an airway into the neck on that child with a poor neurologic outcome. So this is very real and very critical. And I'm so grateful that your ICU team came up with the idea to put a small endotracheal tube in, because that can absolutely be life-saving and much easier to introduce than a trach sometimes. The only other things I would add is that I've never heard of this, but my partner Andy Inglis, who just retired, told me that he responded to the ICU once in this same scenario, and they were actually mask ventilating the patient around his stent. He was shocked to realize that was possible, but they were going ahead and doing it and delivering oxygen to that patient. So I'm not saying I would recommend you strap a mask on their mouth first, but if you run out of options, you could try that, or you could also try stoma mask ventilation. So put a stoma to their neck and try to ventilate. But I like your options better, the trach first and an endotracheal tube second.
Thank you. So next scenario is a 1-year-old child who had presented in the emergency with respiratory distress, and when he was taken to OT, they were not able to pass any tube down because it was almost grade 3 to 4 subglottic stenosis, and they ended up doing an emergency tracheostomy instead of any definitive procedure at that stage. And post-operative, he was being admitted in the ICU. His tracheostomy tube gets displaced in the night. Resident on duty overnight tries to insert the tube back once but fails. So what would you do or advise in terms of airway management here? And how do you prevent accidental trach decannulation for the initial days after trach? I think Dr. Sudeep had actually mentioned the ENT ways of making sure that in an accidental decannulation, you're able to put back the tube. But in case this disaster happens, what are the options, Madam? Will a supraglottic airway help while help arrives?
We really cannot depend on a supraglottic airway device after a patient has had a tracheostomy. And maybe to some extent, we can just oxygenate the patient, things like that. But I think I would post a anesthetist and a surgeon on duty in the ICU. So that will be a better option.
I mean, this almost like on duty only, ma'am. We'll be on duty. Once it happened, that happened to be my, I think, second PCTR or third PCTR. So that child had single stage PCTR. So I was home. The PSU fellow or somebody was also not very experienced. Then I was called. In the middle of the night, saying that the single stage PCTR case, tube extubated, endotracheal tube extubated. So funnily, very often than not, the endotracheal tube comes out when you don't want it to be coming out. So it happens crazily. So it happened. Then I told him that I'll be there in 7 minutes. So don't do anything. Don't try to meddle anything. I'll be there in 7 minutes. And I came here. But that is middle of the night. That don't have to go through this crazy traffic of Chennai. So I came here in 5 minutes. But at the end of 4 minutes, somehow he managed to re-intubate. And when I came here, everything was fine. So the child is re-intubated, child is fine. So as if like he was looking, why are you so hurry in coming here? So it happens, but it's very important to have the tube in. The two situations like what you asked about the tracheostomy, two ways of tracheostomy we are doing. One is the maturation sutures. So we mature the stoma at the time of surgery. That means there is a tract right away. So that is one way. Another way is to have a stay suture. The tracheostomy tube, in case if you have a stay suture, but we don't do stay suture for the reconstructed patients, but the regular tracheostomy maybe we will do stay sutures. In that situation, you can just pull the stay sutures up. So that means you will have some definitely airway so that you can insert the tube a little easier. In case if there is no stay suture, if it is only a maturation suture, you will have definite airway, that's for sure. But unfortunately, fresh tracheostomy, even with maturation sutures, it will be completely closing. So what you need to do is stretch the skin up and down. So you keep one finger up, one finger down, and stretch it up. Then you will have some space, and you can, once you are there inside, you can blindly go inside. So nothing will happen like the other way of tracheostomy where you have stay sutures. The possibility of false passage is there. Here that possibility is very, very, very less. So you can just pull it, get some area where maybe you will get some air leak or something. Then you are there, you can push it in, and if nothing is possible, you use the endotracheal tube. Even a smallest endotracheal tube you can use, that's fine. And endotracheal tube is very easy to put in through the tracheostomy rather than the tracheostomy tube. Thank you.
Thank you, Dr. Thiru, for that comments. So this is so where is the slide? This is again a real scenario which happened actually last week in my unit. So it's a 3-year-old child who had a massive neck mass and airway compression anteriorly. So this mass was extending from just a couple of centimeters below the trachea down to the thoracic inlet, and it was a very well defined mass which was compressing the trachea anteriorly and displacing the thyroid laterally. And the kid came with a critical airway, but that initial part was managed by our anesthetic team in the OR. And then after the procedure, they did extensive neck dissection because they could not remove it in single piece, so they had to take it out in pieces. He was, and ICU was told that he should be kept intubated for a day, and after that he can be extubated. Immediately after extubation, the kid was okay for quite some time, like for about 4 to 6 hours. And then he started to have a stridor, and the stridor was progressively increasing, and the respiratory distress was increasing. So this scenario is real. So this is it's a child who has got post-extubation stridor in the context of an anterior neck mass which has been removed, as well as an extensive neck dissection. Dr. KAALAN, is there anything?
Excuse me,
Yeah.
was there a drain tube in the neck?
There was a drain tube.
Okay.
Dr. KAALAN, what would you? I mean, if I call you on this scenario and you are the ENT surgeon, what would you tell me on the phone?
Well, I would want to get a little bit more information to know what the neck looks like and what form of respiratory support the patient was on initially and what they're requiring now.
So immediately after extubation, we had put the kid on high flow nasal cannula, and the kid continued to be on high flow nasal cannula, but was having increasing respiratory distress, was maintaining oxygenation well. So it was not like a critical emergency at that point of time.
And was the neck flat? Were there any concerns for hematoma or any other findings on physical exam?
No, there was nothing. Neck was absolutely flat. There was no swelling, and after the surgery, they had taken a relook into the trachea, and they had found that the anterior compression had relieved, but there was a little bit of tracheomalacia or anterior wall sagging at that point of time. So they had noticed that. One more thing which I have not revealed is at the time of neck dissection, they could not find the recurrent laryngeal nerves.
Okay.
So they had actually told us that they are not sure about the recurrent laryngeal nerves at the time of the surgery.
Is there any stridor at this point?
Yeah, there's significant stridor, significant inspiratory stridor. I don't have the video. So because we have scopes in the ICU, so they asked me to scope the kid. So we scoped the kid while the kid was on high flow, and this is what we found.
Yeah. So I'm looking at paradoxical indrawing of the vocal folds on what I'm assuming is inspiration.
Yeah.
So I'm concerned for bilateral vocal fold paralysis, which actually, most commonly you would be concerned about edema post-extubation, but the edema would normally set in within, 3 to 6 hours. The fact that this took longer to set in with the significant stridor is consistent, I think, with this.
So
with
as we
that
go in,
diagnosis.
we do
But the
find
malacia, I'm sure, doesn't help.
Yeah. So now we have both tracheomalacia and vocal cord palsy. So the head and neck surgeon who did the surgery did say that I think there will definitely be unilateral cord palsy. I'm not sure about bilateral cord palsy. Even if you have bilateral cord palsy, some kids do not need anything to be done. And we had another case of esophageal resection about 2 weeks back, where it turned out that a kid who had stridor post-op with bilateral vocal cord palsy, even without the bilateral vocal cord palsy not resolving, the kid turned out to go to the ward without any respiratory support. So they are a little deceiving. It depends on the space, is what they told me. So even here, it looked like there is some space. It was not completely paramedian in position. So they actually told me that this is multifactorial. This is not purely due to the bilateral vocal cord palsy. It is due to a combination of multi-level obstruction where you have tracheomalacia as well as bilateral vocal cord palsy. So they said, put back the tube, leave the child for some days. We could have tried CPAP, but the problem is when we keep CPAP for these kind of patients in a unit where there are only fellows in the night, it can actually be more tricky. So they said just because you just put a endotracheal tube and give time. Yeah. So anyway, we ended up re-intubating the kid. We are planning to extubate the kid on Monday. So again, a question mainly to ENT would be, what is your opinion about this post-operative bilateral vocal cord palsy and it getting better over a few days when the swelling subsides versus doing a tracheostomy versus a definitive procedure at this point? Dr. KAALAN?
Well, I would certainly be looking for ways to avoid a definitive procedure or even a tracheostomy at this moment if I could, being so close, so fresh post-op. Because especially in this child, there is likely a multifactorial etiology for the respiratory distress. With the tracheomalacia, there's always some degree of edema that you'll expect from the dissection, both around the trachea and within the trachea, that you may see some improvement on within a small number of days. And then I'm not necessarily expecting the vocal fold, the recurrent nerve injury to resolve within a small number of days or weeks. But even if there's a small amount of edema at the glottis as well that could be improved with time, all of those things I would want to give it time before I committed that child to a tracheostomy and certainly to a definitive procedure. But in this early setting, if I had attempted to extubate the patient successfully and had failed multiple times and we had to do something else, I would still favor a tracheostomy, because if there's a reasonable, if there is a chance, and especially if there's a good chance that at least one side may recover, then that would be preferable in my mind to have a tracheostomy and allow that to recover, compared to a chordotomy or something else that may have lifelong dysphonia, if not dysphagia concerns.
Thank you, Dr. KAALAN. I'd like to hear some Indian perspectives as well. Yeah.
So we had one adult patient, not a pediatric patient. So adult patient, he underwent single stage tracheal resection elsewhere. So he again came back with this stenosis. So we did an revision single stage tracheal resection anastomosis. We removed 4 rings and previous 3 rings were removed. He was fine on post-op day 1. Post-op day 1 night he started developing stridor. So we did a bedside scopy and it showed bilateral local cord paresis, not complete patch. You could just see some movement. So we just gave nebulization. We gave just one steroid nebulization. He was not improving. So we put him on CPAP. After 24 hours CPAP, it became very worse. It was not improving with the CPAP. So we had to go and intubate the patient with a flexible intubation. We kept for 2 days. We extubated. He was again same. He was not improving. Put in CPAP. Again intubated. Went on for 5 days. Then we thought it doesn't work. So we took him to the OT. We did a tracheostomy. We put a 7-size tube. Then we shifted back to the ICU. He was fine for 1 day. With tracheostomy, again we got a call that he developed stridor. So we were very much confused. So we went back and did a scopy. The tracheostomy is out of the place. It was in false tract. So we thought it was because of the revision surgery. 2 times trachea was operated. The trachea length was very short. The trachea was gone posteriorly into the mediastinum. So we took him back to the OT. We put endotracheal tube for the longer conduit. So we put endotracheal tube inside. So we got that long space. We had to put an endotracheal tube. Tracheostomy tube was very short to reach the trachea. So we learned, that CPAP doesn't work.
So the patient with bilateral Walker cord palsy did need tracheostomy in that case.
Yeah, but after 3 weeks it improved. So it was like in
paresis. The cords improved after 3 weeks.
Cords improved.
So you decannulated after 3 weeks.
We decannulated. We removed endotracheal tube after 3 weeks.
Okay.
But, so I just want to know whether CPAP will work in cases of bilateral vocal cord
it does help,
palsy.
but you have to keep it all the time, no?
We kept it for 24 hours. It became worse.
In an ICU setting, we can keep 24 hours CPAP, but we can't send a child home on 24 hours CPAP. So we'll have to, if a patient is bad enough to need positive pressure ventilation, especially the bilateral Walker cord palsy patients, during sleep we can support them, but what about when they're agitated and then they sometimes get blue spells or apneic spells or suddenly stop breathing. So we need to have a safety mechanism as well for those times.
So definitive procedure would be going
so,
for tracheostomy or would...
No, that's what I wanted to ask again. Dr. Thiru, so the head and neck surgeons who did the surgery, they are not at all keen for tracheostomy. The family doesn't want a tracheostomy. So 1 week after this, let's say we extubate the child again and the child fails, and this time we're definitely going to try CPAP because we didn't try it last time. And let us say we give a trial of CPAP and still at the end of 2 weeks from the surgery, we still have bilateral Walker cord palsy, tracheomalacia in this kid. Would this kid be a candidate for a posterior cricoid, posterior anterior cricoid split? It's a 1-year-old child or would this child be a candidate for a posterior
No.
arytenoidectomy?
When we plan any procedure, the definitive procedure in bilateral orbital palsy, that too, you know the cause. There is, post-surgery, and the possibility of just edema or stretching of the nerve and all those things are there. The possibility of recovery is very high, and possibility of compensation is also very high. So in that situation, we generally don't go into any procedure, definitive procedure. So as much as possible, we have to try to do the other modalities of managing. Now sometimes when the CPAP won't work, because as you saw in that video, the child is having paradoxical movement when there is inspiration. So when you are also forcing it with the positive pressure, sometimes the cord adduction may be increased, and also sometimes what will happen when there is epiglottic prolapse, or epiglottis is very flabbing. When you give CPAP, that will push down, and maybe that will worsen the situation. So in that situation, maybe nasal cannula might work. So you will have to think about all the other options when the CPAP is not working well. So you'll have to titrate other issues and manage well without a tracheostomy if possible. If nothing works, then ultimately you'll have to go for tracheostomy and wait before going for any definitive treatment for the bilateral orbital palsy.
Thank you, Dr. Thiru. Please. Yeah.
One more point is, I agree with Dr. Thiru. One thing is, like, in that scope, there's still a bit of cord edema, so probably I would give more time.
Yeah.
And the other thing is, in younger kids, you can do temporary procedure. That's basically you do an interarytenoid hyaluronic acid injection. So that's like Juvederm or Restylane. So what it does is it pushes the arytenoids apart. So that will increase the posterior glottic space. So that will last for about a few months. So that will give adequate time for your nerves to recover. And if that still fails, in the sense once it's resorbed and the symptoms do come back, then you can think of what to do next at that point, rather than doing a track at 2 weeks.
Thank you for just one more question to Dr. KAALAN. What would be a timeline for trach versus an alternate to trach, rather than the conservative wait and watch for 1 or 2 weeks? What would be a threshold for the timelines for this kind of patients?
Just to add to Dr. Thiru's comments, because I completely agree with everything he said on that, is that we would really try to watch and wait before definitive procedures on something that has such a high probability of spontaneous recovery, at least on one side. Helium, like Heliox, is another thing that is sometimes very useful. So I would cycle through each of those alternatives, because the helium and oxygen sometimes will go through a more narrow airway more effectively and provide oxygenation more effectively, sometimes even than CPAP. But each of those modalities should be attempted. And sometimes we've had patients who we extubate on the third try, and they just barely make it with Heliox and steroids and racemic epinephrine and CPAP sometimes, and then it's a high flow wean for a month, and before we can get them out of the ICU. And I would take all of that time, if they give it to me, before I would consider even a tracheostomy or certainly a more definitive procedure. But if we're being pushed and we just can't extubate and we have to do something, if it's within 3 to 6 months for me, I would still prefer a tracheostomy if we have to do it, because the lifelong consequences to that patient will be less than some of the alternatives for definitive surgical management.
Thank you. That helps me with my patients. So I get something
regarding
out of this.
this kind of a thing. There are a lot of restrictions regarding the resources.
Yeah.
Like if you have someone on to 6 months or 1 year, and then you take them up. We, as in India, I'm sure we'll have a lot of problems regarding that. So we need to change according to what
Absolutely,
is best.
And
in
that's
our
the
own
key thing.
setup.
I mean, when I ask something to Dr. KAALAN, I'm looking for
We're looking
the
at what
ideal
we- yes,
answer. But when
yes.
I ask our Indian colleagues, I'm
Exactly,
looking for
exactly.
a little bit of modification in the context where we also need to decrease. So the way that our patients think is, one is if at all there is a procedure, they just want one procedure, and that procedure should be, it cannot have a staged procedure, and it's very top priority for them to decrease the length of stay. So any solution that we provide which involves multiple surgeries or prolonged length of stay is outright denied by the parents. I'm sure that you would.
Yeah, absolutely, and also so I can't deny that, and also, wherever we go in all these meetings, we hearing lot of heliox. So I come back from there, and I will ask our Dr. Bala Ramachandran, the intensivist, who can buy anything from anywhere. So even he couldn't buy heliox for us for the past 10 years. So so that is out of question for us.
I'm done with the scenarios.
Thank you, Dr. Sajith. That was a very, very informative and useful panel that you conducted. You held everybody in rapt audience at the end of the day. On behalf of the organizers, I'd like to invite everybody for dinner at 7 p.m. at Crown Plaza Hotel, Adyar.
Dr. KAALAN, we also would love to have you for the dinner.
I wish I could be there.
Yeah. Anyway,
That'll be your lunch.
But he's going to go have breakfast now.
yeah, I think
Next time.
yeah, absolutely. Yeah.
Next time.
Yeah. Thank you so much. Thanks for being with us throughout the day, and thanks a lot.
Okay.
Thank
Thanks a
you.
lot.
Thank you so much. Thank you.
We'll see you guys tomorrow.
Yeah, tomorrow. Bye.